A very good afternoon to one and all present today. Thank you so much for joining Inform's NCSU chapter. Today we have a special guest, or I would say the industrial pioneer in the areas of supply chain risk as well as healthcare supply chain. We welcome Dr. Mohan Gopalakrishnan from WP Carey School of Business, Arizona State University. Let me introduce his background and how we got connected to engage in this particular presentation. He did his master's and PhD from University of Alabama in management science, and then he joined the Concordia University and worked there for 8 years in the decision science department before moved to this Arizona State University. His areas of expertise is primarily in supply chain risk management, healthcare operations management, and humanitarian logistics, followed by target pricing, target costing, revenue management, and inventory management in retail sectors. He has published various journals, including Management Science, European Journal of Industrial Engineering, International Journal of Production Economics, and Supply Chain Management journals. So right now he is also a researcher in the research group from UN, and he is also a deputy director for the MBA program in the late 2000s. Today he is with us to share his experiences and research ideas in the areas of logistics, especially in a healthcare supply chain. We have experienced in the last almost 1 year time period that how we were tackling these issues in COVID-19 situation. What kind of scenarios and structures we were incorporated in our business group so that we as a graduate students, especially from university setup, can understand what would be the potential opportunities in the logistics sector when it comes to healthcare supply chain. We once again welcome Dr. G. We call him Dr. G. That is how he is very famous in ASU. So the stage is yours. Before we start the presentation, shall we have a group picture? I request all the participants to please open your camera, your shutters, so that we'll quickly take a group picture and then Dr. G will start his presentation. Yermesh, Kabilan, Mariana, me. So on your count.
Is everybody ready to have the photo taken? Yeah, we have. Yeah.
Got it?
Yeah, good.
Dr. G, it's all yours.
Let me share my screen.
Oh, yeah.
All right. Good afternoon, everybody. This is a pleasure to meet you all through this medium. Wish I was in front of you all. That would have made it much more fun. Because as my particular slide says, we all try to do things to plan our lives to get things under control. But mostly we say that we try our best, but things get out of control from time to time, and we try again. And that's the part of the whole idea of resiliency, right? So that's one of the themes that I want to bring up today as we go through this. So I have kind of split this presentation into 3 parts, and I will go through the agenda in a second. And the first part is focusing on the supply chain issues and challenges in healthcare. And so I just want to make sure that even though we may be aware of some of the things, what are some of the pain points that we have faced, and especially because of COVID, that some of these pain points have come to the front and center for all of us to look at and understand. And here is an interesting aspect of that as I observe it, is there is no country that has escaped in facing those pain points, be it a developed economy, be it a developing economy, whoever it is. And then we want to then connect that to what do we know about supply chains in general, and why are these pain points so unique for healthcare? So that's going to be my second part, that whereby I can connect issues such as logistics and supply chain in healthcare. And the last part, I want to spend some time on a case study. The case study was done with a company which responded very interestingly in this COVID scenario. And I'm going to keep it a suspense till we get there because I don't want to say too much till we use that case. So then I want to finish up by a couple of theoretical underpinnings in this whole domain and some critical questions. Now, just to set all your expectations, if you are expecting mathematical modeling and simulation and stochastic optimization, you have come to the wrong presentation. I still want you to stay. This is going to be done at a very managerial level and also at a level of economics intersecting with engineering systems. So that's been my whole area of focus for a long time. Having an engineering background and then coming into management, it kind of helped me see both sides. So while we all make digital models of whatever we want to look at more with a microscope to understand, I also look at it from an economics modeling perspective. So that's what is going to be the kind of the focus. And I was telling Srinivasan before the start that after each of these set of slides are finished, that is one on healthcare, one on supply chain, and finally on case, we could pause for a couple of minutes and you can reflect on what you heard so that we don't have to wait till the very end. And if there are any pressing questions, you can ask me or share any of your thoughts. Otherwise, we'll keep moving for respect of time. And then you could have a question and answer at the end. So I want to give you the flexibility of how you want to do this. So let's get started. So I've got this. First, I want to talk to you about why talk about management of healthcare during COVID-19? Why talk about supply chain and logistics in that space? What is this case study on resilience and innovation teaching us? How do you look at these in a theoretical kind of a fashion? And some critical questions that all of us would be asking throughout the world. And how do we get some answers at whatever level you look at, whether it's an industrial engineering level, management science, economists, marketing people, social science, all of us are affected by this particular pandemic and how we have dealt with from a supply chain standpoint. So that's what I want to do. So let's start with the first one. Why do we want to talk about the healthcare in the COVID-19? This is the data that I got last night. So we still have the world still reeling under it. 109 million cases, 2 million death. And so that's a humongous one in our memory of recent times of a disaster that impacts globally through this pandemic. So that's the first slide that we want to think about. And behind how you manage this is the whole slew of supply chain issues. Number two, every state, every location in the world has started vaccinating. This is a slide that you get from the United Nations talking about manufacturing and distribution of vaccines from countries to other parts of the world. Some countries, India included, China, they manufacture vaccines, US, Germany, others only import and are going to use. So that itself gives you a complexity of flows and logistics. It is not that Pfizer is not able to produce the 120 million vial doses that you need. They have the capacity. They have done the due diligence. They have the resources. But their supply chains sometimes are strained. There might be an ingredient that they are not able to procure in order to get this started. Or they finished manufacturing, but the snowstorm that happened last 2 weeks is impeding how the vaccines get to locations. Or finally, people getting to the location to get vaccinated. So all these are supply chain issues that need to be looked at very carefully. So those, and don't think this is an unprecedented vaccination issue, 12 billion doses to be logistically handled, my friends. So even people who are in supply chain or in operations, you always talk about the Six Sigma, and you say 3.1 defects per million. Even when you take 12 billion and multiply that, that's a lot of defects. So we have not operated at a scale like this ever in the world. And so we'll be falling down, getting up, learning. But as academicians, we are also learning from how can we do this a little better. Hopefully it doesn't happen, but if it were to happen in the future. So continuing our theme on why do you want to talk about the healthcare during COVID-19, if you come now to the United States, I want to bring you back to United States. When the whole COVID started, that's somewhere end of February, beginning of March of 2020, is when we all started feeling and locking down and all. Masks were a very important one, especially for people working in the healthcare. And how do these masks get? Well, I'm going to show you the next slide about the whole healthcare supply chain. But at the center of it is the people who actually deliver the care. They may be in hospitals or health systems. And so they have their own inventory. Somebody manages that and then asks elsewhere to their suppliers. So that's how most of the supplies come, is looking at your supplier and using some system to bring it into your facility to use it. But other than that, the government, each government maintains its own stockpile. That's called the national stockpile. And so they had about 12 million N95 and 30 million surgical masks at the beginning of this COVID. What were needed, even at that time, CDC was projecting how this case is going to go, is 3.5 billion masks, which, by the way, now we have crossed more than 4 billion of usage. This is what they predicted. So there was a huge problem right from the beginning that we are going to run into shortages in these kind of issues. And why is it not that when I need a mask, I can get it right away? You are all engineers, most of you, so you would know it takes lead time. It takes sourcing. It is global supply chains. Some countries have a captive capacity because we at other countries have requested them to hold the capacity and provide us the products when we need. So lack of being able to procure or manufacture at the time you want in this COVID alone has contributed to nearly the 30% of the deaths. So CDC and others were saying 30% of these deaths could have been avoided if we had the kind of protection in order to treat the patients. The other important aspect of COVID, as you saw across the globe, countries that were able to control it better versus not, one critical element is how do you look at testing? So if you can test people quickly and isolate people based on whether they are positive or not, and quarantine them, that was a way of controlling the spread of the disease as much as people getting it and then being treated. Again, the testing needed a slew of supply chain support, syringes and needles and the materials used in the testing and so on and so forth. Again, those were not centrally coordinated. Everybody was fighting for what they had. So that infected the population more than what it could have had we coordinated it. Now, the other one is people have gotten sick. And one of the issues about COVID, it affects your lungs. So people with some pre-existing condition, we have gone into hospitals not able to breathe. So they had to have assistance in breathing, and suddenly ventilators, which were otherwise a very, not that much heard of product in hospital systems, became a very critical component. And the lack of those things also led to far-reaching consequences. So now we're coming to the vaccines scenario. You got the effective challenges in distribution, access, and provision of vaccines. So all this is critical as to why we want to talk about healthcare and COVID. Now, continuing the same kind of a theme, why do you want to know about the healthcare or the management of healthcare? I've got two pictures here, which I want you to look at. The picture on the left as you focus the computer screen, the left is the top 25 supply chains in the world, and mostly in the US. This is done by Gartner. Every year they kind of rank. I want you to take a moment and just read through that names. You know, Johnson & Johnson, CVS, Banner, Medtronic, and at the bottom, foundation kind of a thing, you see some masters that are people, every year they're excellent. Mayo Clinic, Intermountain Healthcare, Cardinal Health. But I don't know how many of you know, when you reflect at these names, they are not all the same kind of companies. Some are hospitals, some are just manufacturers, some are clinics, some are retail outlets providing services. A multitude of players that come together, at least in the United States, to provide you the final service. And so unlike other kind of areas, healthcare supply chain is having two characteristics that are very unique to it. One, it is not completely controlled by the hospitals who provide. They don't have all visibility because they are doctors and nurses and others who are not trained in supply chain. So they look up to outside help, third-party help in everything, and I'll talk about that in a second. And the second one is generally the supply chain kind of techniques have not been well adapted, and I'll talk about that also. What is mean by adapting? Most of the supply chain knowledge comes from World War, the military side, into for-profit industries like automotive, semiconductor, and whatnot, and not that much into the humanitarian or into social sectors like healthcare. So it's an afterthought. It is not the primary competitive force that like you would see a General Motors would have or a GE would have. So those two things, who controls the supply chain and how much of the state of the art in the supply chain practices is already there, both are lacking in healthcare compared to other industries. An example I've given you is the second part of that slide that you can look at. When providers like hospitals want something, they just cannot call a supplier and say, I want this. They interact to two kinds of relationships. One is what's called as a group purchasing organizations. These are organizations that work for multiple hospitals. It's like a club mentality. People might know about Costco or Sam's Club, right? So you have to be a member. Once you walk into that, you don't have a control over the size of the product you get. Whatever is the size, like if you want toilet tissue, you cannot get one toilet tissue. You have to get 24 pack of toilet tissue in a Costco because that's what they get for them. Similar kind of a thing you could look at the group purchasing organization. But on the other hand, Costco gives me a fantastic price for doing that. So from a price control standpoint, these group purchasing organizations are good, but when there is a crisis, they are not able to solve it effectively. So the providers are dependent on them or distributors. Distributors are those logistics entities that buy, hold, inventory things in a warehouse and transport them to the place where it has to be used. Again, they have their own system. If you look at the left one and you see Cardinal Health, Cardinal Health is the largest distributor. Here is an interesting statistics for you, for people might not know. A hospital might not have big revenue. So based on insurance payments and everything, that because the payers pay the hospital, just say Mayo Clinic makes, let's pick a number, $3 billion annually in terms of revenue of treating patients based. Cardinal Health alone is an $8 billion industry. Look at a player in a supply chain of healthcare larger than the healthcare supply chain provider. So that kind of an imbalance exists in the healthcare supply chain to look at. So That's one of the reasons why we want to continuously read the healthcare and understand. Now, the next few slides is what I call as the perfect storm that happened because of COVID. And I'm going to take you through the different things. The first one is the hospitals and health systems, right? You might have seen this. What happened in the United States in the last 10 years is an interesting one because a lot of mergers and acquisitions in hospitals. But the effect of that is the total number of beds available has shrunk from 1.5 million to 900,000 beds. That's a huge deal in today's world of every hospital that needs a bed to treat a COVID patient if they get sick, really sick. So that has had a big impact when you say hospitals are overcrowded, that one alone is a critical one. The second aspect from a provider, hospitals, is, I'm guilty of this for the last 15 years. In my operations class, I teach about how do I do just in time in healthcare. It's a huge deal for my hospital students. It's a huge deal for the chief financial officer in healthcare. He would come to me and say, he or she, hey, Dr. G, why are we not doing more just in time? Because it's efficiency, it is cost effective. So we have pushed and pushed and pushed for hospitals to reduce inventories. And when everything is going well, things are okay. But when a crisis hits, it really affects them. And look at bullet 1 and go to bullet 3, mergers and acquisitions. Why did the beds get reduced? Because more patients, we all, and industrial engineers are guilty of this, we all model the patient flows, and then we categorize the patient flow and say, hey, this can be better done in an outpatient setting. Why do you want to keep it within the hospital? Move it out so that you could have a more effective and efficient flow. So outpatient settings don't have beds. Remember, you would have gone there, you would have gotten an X-ray, you would have gotten something as a diagnostic and walked away. Previously, it was in a hospital system. Now you've moved it out. So that has an impact too. Now, this next bullet is a very critical one. You might want to say, why is healthcare supply chain is seen as a revenue center? Because it's a cost reduction mechanism. If I reduce cost by $1, it goes to the bottom line, to the revenue. So from a cost reduction standpoint is how supply chains are viewed as. So it used to be crazy when I started 25 years ago in healthcare. There were systems where a doctor would come and say, I want a specific type of gloves to wear. And the doctor might get upset if you don't give him that gloves, him or her. But today, that system is completely gone. You go to a hospital, they may have only 2 or 3 types of gloves. So by reducing the variety and looking at standardization, we have improved the cost, but in some cases, it has become something to bite you. Community benefit not equal to public health benefit. So hospitals are set up to benefit that particular community. If that particular community is affluent, it's doing well. If the particular community is not affluent, it has a different impact. But now when it comes to a public health like COVID, those community things are not working the way because they are kind of boundaries around those communities. And last but not the least, I've talked about this, how hospitals outsource risk. Because they are not owning these products, because they are not actually dealing with contracts and buying from a manufacturer, they don't know what the risk is. They leave it to the GPOs, the group purchasing organization or distributors to look at. So that's one of the reasons. So there's a perfect storm from a health system perspective. Let's move on. There was also a perfect storm for suppliers and manufacturers. Remember, if you go back to that top 25, you see Johnson & Johnson and companies like that. They're all manufacturing companies too. So they also have to outsource components, if not full products. And so most of what did we do? This is where healthcare followed the other supply chains. We said, hey, go global. Why do you want to do it within the United States? So they went and started cutting their manufacturing capacity in the US and started moving it first to Mexico or to Canada, then to China or Asia. So that lengthened the supply chain like any other supply chain, but this is a very critical supply chain. When things happen, it happens very fast. Response time is so critical. And then again, the cost pressures, they would then go and say, who's giving me the lowest cost? And so the quality took a beating and things of that kind. Again, go back to the same thing I talked about in the previous slide about risk. Anytime I don't own my bill of materials, my risk is not mine. I outsource it to somebody else, and I get to see only the impact of that risk playing out, not mitigating it right away. And in a lot of cases, the cost also led to the pressure on single sourcing so that the volume can be increased and a better cost can be obtained. So economics plays a big role in how supply chain is structured and its impact. Let's see, how are we doing for time? Okay. As we move down the supply chain, the next one is all this intermediaries. So we blamed them a lot, right? We said the group purchasing organizations and distributors were the reason, but they also faced a perfect storm in COVID because they were being pushed in a lot of ways, not by themselves, but by the hospitals say, hey, we want standardized. Remember I told you, my friends in hospitals would come to me and say, hi, Dr. G, how do you do just in time? So I would teach them standardization, then they would take it back to their GPOs and say, why are you providing me with 7 different types of bedpans? Why not just 2 types? That will standardize things for me. And I could want to substitute one for the other. Go to the same manufacturer. It's like the Southwest model, right? All aircrafts look the same, so it's easy to maintain. Parts are interchangeable. So that type of a mentality pervaded a lot of us. There's nothing wrong. It's got its pros and cons. We are unfortunately living all the cons right now. So distributors the same way. And then regulation. Healthcare is a very, very regulated industry, as you know, everywhere in the world. So it's not like you can just change things. Even a bed in a hospital has to be classified. This is a bed for pediatrics. This is a bed for cardiology. And you can switch one to the other because of the regulations. So there's inflexibility in how you handle things due to regulation in healthcare. Keep moving. Now the perfect storm comes to the government. So I finished these hospital systems. I came to the manufacturers and suppliers, to the intermediaries, to the government. Government was completely short-sighted. I don't want to even get political about it. I'm just saying, because we industrial engineering and other kind of people have done all these scenario planning things through simulation. What if a pandemic hits? Don't tell me we have not done it. Don't tell me we have not provided that information, but to whom does it reach in a government and how much they pay attention to is dependent on how much funding goes into it. So if Stockpile is one way of managing this, and the Stockpile was underfunded and undermanaged because they directly doesn't manage. If you go to the United States Stock Fund, a national stockpile, it is managed by McKesson. McKesson is one of the largest distributors in the healthcare. But McKesson is mostly making money by working with hospitals and others. So they give a very, their contracts, I've read the contracts, it's not very strong with the government. Like if you fail to bring something, how are you penalized? Is part of the contract. That's not very strong. So the strategic national stockpile was not managed. Again, government, unlike hospitals, is even worse in trying to understand who are their tier 2 and tier 3 suppliers. So I don't know whether you know this, when recently McKinsey's, the consulting firm, did a study about how for-profit industries got affected because of COVID, where most of their suppliers were in China. And when the the pandemic first hit China, and their suppliers were all shutting down because of health reasons, Chinese government stepped in and protected them by saying, because of health reasons, none of your contracts are valid with your exporting contracts for the next 6 weeks. Which information did not reach the people here in time. So there's going to be a 6 weeks delay in whatever comes from there. and there is no protection for that. So that lack of knowledge of tier 2 or tier 3 suppliers, it may not be your main supplier, but the main supplier might be wanting something from a second tier supplier who's at risk here. And the big problem, like anywhere else, is information systems and how much of digitization has come into healthcare and how much of it is transparent and shared. So that's a huge thing. So this lack of understanding about public health or social health, however you want to call it, created these huge shortages in the PPE and also for ventilators, the two pictures that you see. So let me keep moving. So here are the key takeaways, and then I'm going to pause and see if you have any comments. So this is our first point of pausing. So we talked about managing healthcare in the COVID. Why do we want to know about it? So the first takeaway is inaction or lack of timely action of a centralized planning and response, especially in the US, to understand capacities. So later on, people started rushing, and I'll talk about that. They asked Tesla to manufacture ventilators. They asked GM to manufacture ventilators. So they did all those kind of war efforts, but it was not done in a timely manner or with a thorough planning. So that led to shortages. Everybody says in the United States, market solutions will be helpful, but market solutions fails because market solutions needs financial incentives. And if the right financial incentives is not, so a lot of incentives was given to vaccine manufacturers. So you saw them almost bring out the vaccine in record time. Whereas the same amount of incentives was not given to the supply chain players. So that market did not provide that. The hyper-globalized nature of the healthcare supply chains, as we were talking about, it's not just local. 60% of the N95 mask making capacity, my friends, is in China. 60% of the world's capacity. So that's a captive capacity of one country. If anything goes wrong, it's going to affect supplies. So I don't want to leave you with the feeling that the future is bleak. No, we are all good, resilient people. We always come out of this pretty strong. So we need a mechanism to engineer a sophisticated web of both economic side of things, which is your incentives that aligns with divergent interests. How do you share risks and rewards? And also the computer science and the whole data analytics side of data transparency. All these are starting to happen. And hopefully this will be our kind of wake-up call for that. So Srinivasan, I'm going to stop here, stop sharing the screen for a second. And so that I can look at my chat session. If there is anybody wants anything to chime in or question, let's take about a couple of minutes to do that. And then we'll move on to the next set of slides.
Okay, so yeah, that's a great discussion, Dr. G.
Yeah.
So I just had not a question, just like a general discussion. Like, do you think if COVID-19 were on the like China was on the first country to get highly impacted with COVID-19, would the impact overall around the world have been much lesser? Because China has this, manufacturing capacity that's kind of like in the global supply chain. They have a really high capacity for that. And they were the first to get really impacted by COVID-19. But what would have been the scenario if that wasn't the case?
You are absolutely right. I think the impact would not be as tremendous in terms of the lives lost because of the shortages. I want to be very careful when I say that. Because these scenarios, we human spirit is such that we love crisis and we rally around it, and the number of lives saved is almost unimaginable compared to the number of lives lost. So, both sides are there. However, when I look at only the data on the lives lost or the issues that created extreme conditions for healthcare professionals because of the lack of these kind of issues, which is one is your ventilator and two is the N95 masks. And one of them is captive capacity is China. Your thought is probably right. The impact might have been a little different if we had even if it had spread out that capacity. This is where I'm going to put a slide at the end saying, how does globe come together How does UN and others come together from a supply chain standpoint? Everybody's coming from a political policy, all those kind of standpoints, but we need to come grassroots, grounds up. And we need all of us to support that. I've got something from, I don't know, some countries are also setting aside the duration between first and second dose. Yeah, absolutely. Absolutely. Yeah.
Hello, Professor. I am Atanu from Durham University Business School.
Hello, Atanu. How are you?
Yes, thank you, sir. So it's very interesting discussion. I'm sitting here in UK, and as we know, UK government is also sort of dilly-dallying on what is the duration between the doses. They initially said a couple of weeks, then it's pushed to 5 weeks, 6 weeks. And this also creates a lot of supply chain uncertainty, right? How do we roll out the vaccination? Shall we do this as planned every 2 weeks? And we have already created a priority group of people, or shall we delay and give more people the first dose and the second dose is delayed? All of these has supply chain implications from the government perspective. They have to balance the economic as well as the healthcare, public health related objectives. It seems to me as a very complex problem. And we don't have the answers. So do you have any thoughts on this? How we should even address this?
If I had, I would be in a different forum making money. I'm just kidding.
Just some thoughts. Even as supply chain academics, how we should address this problem?
I think one of the issues, my friend, in any of these mass healthcare kind of settings is configuration of a supply chain. I want to use that word very deliberately, configuration of a supply chain. What do we mean by configuration of a supply chain? A lot of places, it is either centralized versus decentralized. These are two different configurations, right? You could either have a store every street corner having milk, very decentralized, so that your walking distance or your driving time is really reduced, very convenient for you. But the cost of maintaining inventory of all these decentralized places will increase the cost of the supply chain.
Sure.
On the other hand, we can put only 5 or 6 locations of these milk as an example. In this case, it's going to be vaccine, which means you could pool the demand. So Atanu might not be drinking a couple of tumblers of milk a day, but somebody else drinks 3. So between those two, there's a pooled demand that a centralized one would address more effectively than decentralized. But then there are the trade-offs in terms of driving distance, people's access and things like that. So from a policy perspective, which is, do I do it in 2 weeks? Do I do it in 5 weeks? To an operational perspective as to how I do it, there's always a gap.
Yeah.
And this gap is also due to economic constraints. Gap is also due to this is an unprecedented time of the whole world facing it as opposed to just UK or US or China or India. Because we have examples in the past of bird flu and all those kind of things, but they were so isolated sometimes and only in certain part of the world that we were able to either contain it or address it that way. This one, there's Canada that sits north of my border has not gotten vaccine yet because they signed up with UK, I'm sorry, with Europe, and they got into trouble in terms of European kind of systems now. And that is affecting, to some extent, Brexit is affecting some of these. So the logistics of this is controlled mostly by politics, and that has an impact also. So let's keep it at the level of understanding the configuration of supply chains that are needed. And hopefully this will give us more in-depth idea about the right type of configurations given certain types of parameters that we want to use.
Good, thank you, sir. Yes.
All right, I'm going to stop and start sharing so that we can continue. All right, where were we? All right, so that's my key takeaway. So now I'm going to move on to answer some of Atanu's questions and others. Is let's understand supply chain and logistics, because this COVID has given a wake-up call. And don't forget, it's not just the healthcare supply chain that took a beating, it's all supply chains globally took a beating. People were not prepared, and ASU did a lot of research on this, and I can share these slides. So some of these particular slides have links. So when you go to ASU research, that slide link is to a Harvard article, Harvard Business Review article that we all wrote on studying some of these issues. So as I was telling Atanu, we had numerous disasters in the past. So risk in supply chain plays out in two ways. Probably you know that. One is risks with high probability of occurring, but low impact. Example, if you forecast wrongly something, then it's not a big deal. You can adjust the forecast next week. The chances of doing a wrong forecast is very high, and so on and so forth. However, it is the low probability, high impact risks that are more critical, which is like the COVID right now. Low probability of occurrence, but the impact is so much. That's not a well-studied area. It's studied well, but it is not to the level of understanding in a repeated fashion, because these are low probability events. And the other one is the complexity of the global supply chains that we talked about. Everybody is saying, let's map your supply chain. It's not easy. When you have a global supply chain with 3 and 4 and 5, and Ford just found out they have 8 tiers of suppliers sometimes. And going to every one of them is not going to be easy. The third point is most places you either make or buy, right? So you either do yourself that product or you buy it from somewhere. The buying function is called the procurement. If you go and talk to procurement people in supply chain, they are measured by cost savings. How much, remember I showed a slide that said healthcare supply chain is revenue generating. And that's because of cost savings. So if I can do everything to cost savings, it's not based on revenue assurance or public good. Procurement is not measured. Now, supply chain disruption is not often a part of supplier performance metrics. So I don't measure what do I measure my supplier? I measure a supplier on quality, on price, on delivery time. I very rarely measure the supplier, how good are you when there's a risk in assessing. It's becoming more important, my friends, because of cybersecurity. Today, many suppliers are also asked to present how good their cybersecurity is. It's a risk, but we do it only in that area. We don't do it in all the other areas. And also there's this general lack of collaboration. And if you see, I've put 3 sectors. Generally, people talk about only 2 sectors, private sector and public sector. But now more and more, COVID has taught us there's a social sector. Because when this affects, and when people cannot get back to work, and when our factories have to shut down because social distancing is not possible, it's the society that gets affected, not just that company or not that particular community. So there's a social sector based on this pandemic happening. And that's where we talk about the government and the national stockpile and centralized way of managing supply chain. In some countries it is. Atanu might say, at UK, it's a centralized supply, healthcare. But even there, supply chain is not managed that effectively compared to other parts of the world. So that's why we want to talk about the supply chain. Now I'm going to walk you through some slides in a very supply chain 101 kind of a course, but connect them to this particular healthcare. So I'm going to ask you a question and a number of slides saying, what is global supply chain? So I'm going to let you read this. So a critical component of supply chain is value, right? So value, what is the value proposition of this supply chain? But what is happening in the world, if you think about it, the value is not static. Think of Amazon. 20 years ago or 15 years ago, If Amazon says, I will deliver it to you in a week, oh, wow, that's great. They're going to deliver something to me in a week. Today, the same value proposition is, can I deliver it the same day? Can I deliver it within hours? So look at the value proposition of a particular company from a particular metric standpoint is not static. So that's one thing that we have to understand. The other important thing about value is sometimes it not be intrinsic. It could be extrinsic. What do I mean by that? When you look at delivery time, it's very intrinsic. I know it did not come on time. My pizza did not arrive in 45 minutes. I can be very sure about that. But then there are value that is given because of visibility kind of things. Remember, when you do a FedEx, they tell you your package is right here at this location. It is supposed to arrive here by this time. That's not a direct value proposition, an indirect value proposition that a lot of people value. But just telling that my package is at a location alone is not enough. Like it happened to me just a couple of days back. I was going to get something from the East Coast. FedEx takes it to Memphis, and from Memphis, it comes to Phoenix. The snowstorm shut down, so it got stuck in Memphis. The flights couldn't come to Phoenix. So all they told me was it's stuck in Memphis. So visibility wise, I know that was in Memphis, but it didn't help me. I didn't know when it's going to come. And so if I had the wherewithal to know, and if I could remove it from that FedEx facility and put it into some other way of bringing it, that's transparency. Transparency now talks about alternatives to managing a risk when you have a visibility to the information. So two are very different kind of things. Just having a dashboard of information doesn't mean anything. How are you acting on it? How are you understanding the impact? And what are the alternatives? If you are transparent to that information, then it is a complete kind of cycle that helps. So the value has an intrinsic as a direct aspect to it, which is not static, and it has an indirect aspect to it, which is also changing with technology now. Let's move on to what is global supply chain management. So what this particular, kind of a comedic picture is telling us is more and more people are looking at logistics in a very customized fashion, not one size fits all. Again, it's like, Amazon used to do. They had a centralized warehouse. There are only 3 warehouses 20 years ago across the United States. So no matter where your demand came from, it has to be fulfilled from one of these warehouses. That's all. So if your demand came from the East Coast, there was a warehouse close to St. Louis. If it came from West Coast, it was in California, or in Seattle rather. So that was not enough. As they started shifting the value around how fast they can do, they had to open up multiple warehouses and how to use those warehouses. Today, in Phoenix, at least I know, there are 7 different types of warehouses that Amazon has. It's got its huge centralized warehouse that is used to fulfill anything that you don't want urgently. It's got warehouses that deal with large items, like if you're ordering a kayak or something like that, a ship or a big item, they don't want to handle that in a general warehouse, so they got specialized warehouse for that. And then you have warehouses that are very pop-up, very small warehouses that deal with day-to-day demand if somebody has to get it on time. So this customization of logistics is becoming more and more. Look at the testing itself of COVID-19. There's something called a PCR test. Either you do a nasal swab or you have spit test where you spit your saliva and then you give it to a place where they could use this PCR as a way of creating that double helix of your DNA and pattern matching it to say, do I have COVID or do I not have COVID? But in order to do that, ASU is doing a lot of the spit test now. So the way ASU is doing the spit test is it is allowing students to drop it off at different locations. So you could go pick up a toolkit, split into it, and drop it off at a location. So logistics is now customized in order to help students. Otherwise, they have to travel to a central location, they have to get tested, and so on and so forth. So this customization of logistics is getting critical in global supply chain management. The third one, I'll let you read this. It's about risk management, right? So we talked a lot about this. So the whole purpose of supply chain is identifying and mitigating that risk. So one of the things that we keep coming back to is we know about the risks, we know about the identification, we know about even to predict, but from a mitigation standpoint, we need to have a lot of collaboration among players because one player cannot solve it. So that's what COVID is teaching us. And that data transparency would help us better identify or even predict the risk. The last one in this is what we call as process excellence. So when you want to move a supply chain to a world-class level, it has to have process excellence. And process excellence in supply chain means three things, which is called a AAA supply chain. You could take this with you anywhere you go. And one is called agility, which is more on a day-to-day basis, how responsive and effective are you? The other is called adaptability. Strategies needed to make a supply chain dynamic. And Atanu talked about this when he said, when I shift from 2 weeks to 5 weeks between doses, how does my supply chain gets adjusted to it or the other way? So that dynamism is needed, is called the adaptability. And the last one is the most critical one, is alignment. If each player in the supply chain were to just optimize their own profit and not the overall effectiveness of the supply chain, then you have a problem. So the diverse interests and incentives have to be integrated to have mutual benefits and success. So those are the three things that are important. So Srinivasan, if there are no questions, I will continue, but there are any questions, let me know. I'll pause here for a second. All right, I'm assuming there are no questions, so let me continue then to go to the third part of the presentation. Which is the case study that we did in understanding all that I've talked about right now. This was done by a couple of our fellow faculty members here. And one of them, Hitendra, is actually runs a company called Green Dust that does a lot of reverse logistics, that is picking up products at the end of a line and bringing them back, and rather than just recycling or disposing, how do we get more value out of that in repurposing certain things? So he was a valuable one for us as we did this case study. Before we get into the case study itself, I want to kind of posit a couple of things for you to understand. So everybody talked about this toilet paper issue, right? So toilet paper shortage was there. Was this a supply chain problem? The supply chains were pretty solid. We had supply chains that are almost 200 years old in manufacturing these toilet tissues. And so nothing was wrong with that. However, there were two issues, right? One is from a demand side, there was panic buying. So when panic buying happens, supply chain doesn't know. It's looking at the signal that is coming in. It's predicting some of these signals. But if it's a panic buy, then you get the blimp. It doesn't know, should I use the blimp or should I wait? So the panic buying created some issues before supply chain figured it out and settled down. But the second side was the supply side. because many people started working from home, there are two kinds of toilet tissue products manufactured. One is for household use. The other is for businesses. When you go to the restaurants or to airport and all those kind of things. And again, as I was telling Atanu, the configuration of the supply chains for the two are not the same. So suddenly one side of the supply got shut down, which is the restaurants and travel and everything got shut down. Whereas this one, which is your home, went up and it had to reorient. It was not that easy. It's like a big ship. You can't just turn it. You have to take slow steps. So those were the two reasons, but those two components are critical as you look at this case that I'm going to present. The next important thing I want to pass it before getting into the case is uncertainty framework coming from the previous slide. You might have seen this. Most of the supply chains deal with two kinds of uncertainty, demand versus supply. And that creates a simple 4-quadrant kind of a situation. Demand is uncertainty in demand is low, supply uncertainty is low. That's a fantastic place. That's your effective supply chains or efficient supply chains. That's Walmart. They know exactly what they're going to sell, how much of a particular shampoo they're going to sell in a week. They know they can calculate backwards. They would know how much inventory to maintain. And so they can run an efficient supply chain, which is low on cost. So it is only the supply chain operational cost that they have to worry about. Inventory cost, logistics cost, and so on and so forth. Move to the quadrant number 2. Now the products behave like fashion products. When you look at fashion, demand is unpredictable. Is this fashion going to take off? It might. But the profit margin on that fashion is very high. So when you take off and you don't have enough to sell, then you are losing money. So you need a very responsive supply chain. So if you look at efficient supply chain, inventory is a bad word because you want to reduce, because you know exactly what you're going to sell. When you go to responsive supply chain, inventory is a good word. If you have inventory, you can sell it, which means you are making more money if it's in the for-profit world. Now let's look at the bottom two quadrants. Supply in this case is evolving. An example would be when you look at a hydro-powered electricity versus a windmill. We can be more certain about the kind of power that's coming out of the hydroelectric power mill. From a windmill, it has got a lot of losses and you don't have enough windmills. So the supply is still evolving in that particular domain. So when you have a supply challenges like I talked about in the toilet tissue, suddenly the supply challenge has to happen because these restaurants and other places shut down. Then you're talking about an evolving supply chain, and so you want to start doing a lot of hedging. How do I hedge? So what do power companies do, which is also an interesting one when you look at Texas and what's happening. They don't look at just the hydropower, they look at portfolio of power and how do I manage the risk. And the 4th quadrant is the worst quadrant to be, which is both the demand is uncertain, the supply is uncertain, which means you need to have all 3 of the quadrants strategies used. Now let's look at PPE, your protective equipment like mask. Under normal situation, the PPE is something you can always predict because it's not like every day everybody is going to wear a mask. And it's not going to be public wearing a mask, it's only healthcare people wearing masks. So PPE used to be like an efficient supply chain. They know exactly what they want. They don't want to have too much inventory. So they have the right inventory. Ventilators, on the other hand, is a little bit, it has to be customized to the type of disease that you're trying to treat. So it's a slightly uncertain demand there. And so you want to have a little bit more inventory and have a responsive supply chain. If you look at something like evolving diagnostics, the picture that I've shown you there is open MRI. Open MRI is for people who are worried about being claustrophobic in a closed MRI kind of a setting. There are not too many of open MRIs. The supply is limited. So what do? A lot of hospitals ask 1 or 2 locations to have it and share, so they risk pool. And the last one, the agile supply chain. So what happened to PPE and ventilators? Because the demand surge was so much, the uncertainty was so much, and the supply was not available, suddenly you had to act like an agile supply chain. And how can you act like that? We will show you an example next. So what did we do? We started doing 2 things in the United States. So one is called Allen, and ASU is a big part of Allen, which is called the American Logistics Aid Network. What we do was we almost worked like a call center. We knew that the PPEs were available at some point, but we know the demand was somewhere else. So we were trying to do the Uber kind of thing, how do you match supply and demand? So we did a lot through Allen. We had to get that agility going. A lot of students volunteered and so on and so forth. The government went to people like General Motors and said, hey, start building more ventilators for us. Of course, General Motors knows how to build cars. They don't know how to build ventilators. So they went to somebody like Siva Logistics and said, hey, Siva Logistics, let's get a patent. So they got a Ventex. Ventec is one type of ventilator, and you see the picture there. So they got Ventec's blueprint. Ventec was ready to give it to them because Ventec could not increase its capacity. And so General Motors started building it, but actually it was Siva Logistics that managed the entire supply chain to build. And Tesla was also trying to do this. Now imagine somebody comes to you and say, I want to build a ventilator. It's not going to happen tomorrow. So the lead time to even start manufacturing these ventilators was 3 months. So remember, we are in March or April of last year, people are dying, and you can't tell the hospitals, you have to wait 3 months before you get a supply of ventilators. So California did something interesting. That's my case study. This is just about reverse logistics. I'll skip this slide and go to the next one, is refurbishing ventilators. So the company that we studied is called Bloom Energy. You can go Google this company. It's a very interesting company. It actually manufactures fuel cells. So it produces electricity using fuel cell. That's the company. It's a venture capital company. The founder of the company worked for NASA, did all kinds of electrical experiments in space, and perfected the technology and brought it back to civilian technology. So the kind of boxes that you see is what Bloom Energy manufactured. These are called the Bloom Energy boxes. Each box can produce X megawatts of electricity. And people like Google and Amazon and others in their large headquarters have this type of electricity. Just like solar, this is another form of producing the electricity. So that's what the company is. It designs and manufactures. So the California governor came and asked this company, hey, there's a lot of ventilators that are just lying around without being used for a long time. If we collect them all and send it to you, he didn't ask this particular company, he just put out a kind of a RFP or a request for proposal, who can refurbish them, which means take those ventilators, take them apart, test every part, fill up the fluids or whatever, it's like a maintenance, put it back together, recalibrate it, and then send it back so that they can be used. These ventilators were sitting in warehouses or not being used for a couple of years. So by regulation, you cannot just take them and send them somewhere else to use. So that's what was called refurbishing. So as I've written there, taking in active or mothballed ventilators and retuning them to be useful. So less lead time than manufacturing. And so did Bloom actually do it? So this is this, other part of the story. The picture there is the California Governor, John Newsom. And this is in the facility that Bloom actually put together for doing the refurbishing. They took a warehouse, they converted it quickly into a manufacturing facility. From the time Mr. Newsom gave this request to the time the Bloom Energy was able to send back refurbished ventilators was 3 days. Within 3 days, they put up a manufacturing facility, they got the ventilators, they refurbished them and sent them back. And to date, they have done almost 1,200 units of the ventilators. So it's a great story as to how you repurpose a supply chain to build agility into a production system. So they were looking at the supply uncertainty and trying to do that through agile practices. So, and so they were able to, then once they finished California, they had another unit in Delaware. So Philadelphia and New Jersey came to them saying, we have a same problem. Can you work with us? And they kind of replicated this process overnight with their Delaware facility and did that. So I think they finished about 1,000 units there also. So 2,000 units in all is what they have kind of done. So it's a fascinating one as to what a company could come and help in the agility of a supply chain in order to do this. So those are some pictures of actually people working on these ventilators, recalibrating them, putting them back into the boxes in which they came, actually doing tests. So they had to do what's called as a lung test. Now imagine this is not a medical company. This is electrical electronics manufacturing kind of a company. So what they did was they went to Stanford and went with the biomedical engineering department of Stanford and asked them, hey, how do I set up a lung test? So Stanford sent a couple of its engineers to them, and using balloons and things like that, they set up a lung test so that they could actually see that the refurbished ventilator is working, because you don't want to send it all the way to the hospital to find out that it's not going to work. So they had to learn this fast. They have to put a setup together. They have to work with their logistics companies to bring products in, bring tech products out. They could not choose where it goes. So they had to take it back to the government. So the government would say, this has to go to this hospital or that hospital. So this was done in lightning speed to finish this. If you get the slides, you can click on this link here, and there's a YouTube video that kind of explains how this all happened and what the California governor talking about the outcome. So what are the lessons learned? At least this is the lessons learned for Bloom Energy, and something for us too. The can-do attitude. So I talked to the CEO, the COO, and people who actually worked on this project. I did about 15 hours of interviewing with them. And I could come out, this is my statement. They had a can-do. I can do this. It's a challenge I want to face, kind of an attitude. And then their supply chain practices were very interesting. I'm going to share a theoretical viewpoint in a second, and how they practice supply chain in their regular job actually came back to help them in running the supply chain for the refurbished product for California. And so this reverse logistic technique was used to handle this uncertainty. Then they shared those practices. Mayo now is doing part of that as they got this idea, but Mayo is a company, Mayo is a hospital system, so they know about ventilators. So they didn't have to learn, they just took some of the ideas and they're refurbishing. Whereas Bloom was able to repurpose that in Delaware also. Now, very interesting thing. So you may think, oh, this is something Bloom just did to help the community and it forgot about it and went back to doing it things. No. This is where human spirit and innovation comes. So if you think about ventilators, it's a very interesting, fascinating area. A ventilator is used for one patient. You cannot take a ventilator and say, let me share it with 2 patients because of the breathing kind of conditions and whatnot. So that's exactly what Bloom is now trying to do. Could I take a ventilator and somehow repurpose it to feed multiple patients. So they're working with Stanford, and they have come up with a patent in how to do this. So I talked to the CEO and asked him, why did you think about this? He said, we are problem solvers and we are engineers. So as we were doing this new product idea came into our head as to why we cannot do this. And we put our resources together and we were able to do that. So now I was even told that they got their first order from India to send some of these. They've got the FDA clearance for the patent, and they're testing out in countries right now. I'm not sure if they're doing it in the US. It may be a regulation issue, not the product issue as to where they do it. So that's some of the lessons came. There's an innovation that came out of this. There was a lot of supply chain practices that were used. There was an agility way of doing things, or agile way of doing things. All right. I'm going to finish with 2 more slides, and then we will go have a question and answer after that. So there are 2 theoretical underpinnings that I want to kind of talk to you about. Remember this slide I showed you before is this slide on demand uncertainty versus supply uncertainty. From an economics perspective, if you are in quadrant 1, which is your demand uncertainty is low and your supply uncertainty is also low, the only cost that you're worried about is the operational cost. If you run too many transportation, then your logistics cost goes up. If you buy a lot of items, then your inventory cost goes up. If you are not proper with your manufacturing practices, your manufacturing cost goes up. So these are the kind of components of the cost which are easy to manage actually, because both your demand and supply uncertainties are low. So you can forecast better and do this better. When you move to the responsive supply chain, that's quadrant 2, where the demand uncertainty is high, fashion as an example I gave you, but the supply is not high. You could still supply the products. Then you're talking about market coordination cost, the cost to coordinate demand. So by having more inventory, you probably coordinate that better as a strategy. So ventilators actually fall into this. And so if you look at ventilator versus PPE in a normal situation, you would see more inventory of ventilators than PPE in a relative scale, relative to what they need for the patients. Now, if you go into this particular one where the supply is uncertain, the demand is not, again, as I said, the different types of supply sources that you have, then you normally do a risk pooling. You pool different resources together. So the risk pooling cost, the cost of pooling becomes very important. I mean, there's criticism in Texas saying they relied more on one type of energy versus another. Now the discussion is going beyond the political circle. If you want to look at it, what's the portfolio of energy that they need to maintain so that if the next freeze comes, they are not, completely shut down with lack of power. So it's a supply side discussion. The last one is the agile supply chain, where all these 3 costs become relevant. If you think about Bloom, that's what it is. They had to be very efficient in how they manufactured or refurbished. They found that out. The California government started coordinating where they sent, not Bloom, so that they address this cost. And all their suppliers came together, their logistics service providers came together, providing them with the services because they didn't know when the refurbished thing would be available to be shipped. So they needed support on that in terms of risk pooling. So this is one takeaway, is these costs. So any work that you do, even if you build a simulation model on looking at uncertainty, you may want to look at, am I looking at the right cost in analyzing my model? Here is my other slide. This is a very busy slide, so I'm going to spend a few minutes talking about this. This is called the supply chain practice view. This was developed by my co-colleague here, Craig Carter, whose article is listed here at ASU. And what it is, my friends, is most of the competitive nature of a company comes from 3 things, right? The process, the people, the technology. These are the 3 things. how you put it together provides the competitive nature of the company. Now, if you think about leave out the people, if you think about the technology and products, then you're talking about resources, mostly that resource, and it could be people too, specific type of people. So most of the research in supply chain is done using the resource-based view of a particular company. Now, resource can either be inimitable or imitable, which means your resource can be copied. If you have Microsoft, if you have Zoom, I can also have Zoom. It's imitable. You can say, because I have Zoom, I am more competitive than you, because I can get it too. Whereas you may have a specific feature in Zoom that you have developed and used, which I don't, then it becomes a very unique, unimitable or inimitable kind of resource. So inimitability gives you more leg up in competition, right? Now, let's go towards the right on this. Now you are looking at, this is just, when you look at the resource-based view, the quadrant 2 here, it is one form. But when you travel this way, it is multiple forms. Your supply chain. Supply chains are made of relationships. So the relational view of your firm is how well you are dealing with your suppliers and how much they are ready to do. When people talk so much about how China shut down and things, but people don't talk enough about how much China tried, even at COVID, to supply for the rest of the world. We have case studies done where when Wuhan province shut down, the suppliers around Wuhan were still alive, or you know, the companies were available, but the transportation shut down because airline traffic shut down. So do you know that many companies around Wuhan use the roadways to ship things to the Trans-Siberian network in Russia, and from Russian railway reach Europe, and from Europe start distributing? And they reconfigured this within 10 days to doing this. So they were able to be agile because this relational view is very critical. If Russia said no to China, then this is not going to happen. So there was that relational view as to how, because one had the resource, the Trans-Siberian railways, the other had the products. So how do you match this? So the relational view is very important. But these two are very strategic. They don't happen all the time. They happen sometimes very critically. So you come down where it is imitable kind of things. What are imitable? Practices are imitable. When you say that I do just in time in your company, I can do just in time in my company. I can use that practice. It's only a theory. Then I adapt it to my company. So the practice-based view of a firm is how well supply chain practices, and I've given some examples here of the kind of supply chain practices. A supplier balanced scorecard is a way of managing suppliers. How do you select your suppliers? That's another supply chain practice. How do you integrate suppliers internally to the organization? And you can have the practice at an individual, team, function, or organizational level. So now the imitability is weak, but the practices are strong. And as you cross this diagram here towards the supply chain, that becomes even more interesting. How do you jointly practice something with your supplier? So when you go back and look at how agility was brought by Bloom, they actually did not use too much of these resources because the resource was very limited. They needed. All they needed was to get the ventilators and use their talent to check and refill and things like that. So it's not too much resource, but it was the supply chain practices. When did products come in? How did the quality control happen? When did the supplier the logistics service provider take out the products? So all those supply chain practices that they were good at in their regular work, they kind of adapted it very quickly to this refurbishing. So it was this practice base and the supply chain practice that actually helped them to become agile by managing the costs of coordination and risk pooling. So that's what is the story I want to tell you. And finally, I want to leave you with these questions that you may want to think about. So the first question that I have is, how do you develop strategies around commons? Commons is this set of goods that are needed. Again, don't forget, I am relating these questions to healthcare, not to general supply chain, but to healthcare supply chain. So commons is this national stockpile of PPEs is a common. We better get that act together. As a matter of fact, as I'm speaking today, because I've committed to this, Srinivas, and I missed out on an important meeting, Mayo and 7 other service providers are meeting with the federal government today. I mean, one of my colleagues is attending that call, is talking about this. So I'm not putting something here where it's going to be just in a slide. It's already the discussions have started. What should be the size? Who should pay for it? And all those kind of questions. So how do you incentivize the private sector to contribute to these commons? Because what happened was, when we had the bird flu a few years ago, we needed masks. At that time, government said to one particular manufacturer, please produce more, we'll buy later. So the producer, the person produced 10 times more than what is needed. And then the bird flu did not take off like the way COVID has. So they did not need those extra ones, but government went back on its promise and did not buy it. So the supplier went bankrupt and shut down the operation. So this time when they needed N95, that supplier was not available to produce. So that incentivizing the private sector is very critical, and it's not an easy conversation, right? It's a risk conversation. So the second question is how to develop global supply chain governance. Now, from a local or a national, how do you even work with other countries? If you look at it, unfortunately, what happened? In the beginning of COVID, every country shut down. Nobody can travel from one country to the other. The resources were to be used only for that country. Even certain medicines could not be exported. So we kind of shut down ourselves. That's not the spirit. So moving forward, how do you, at least from a supply chain standpoint, have a global governance? Because the countries like Africa have been hit very, very badly because of some of this. And that's one of the reasons why the morphing happened in South Africa, because of some variants that happened. So how do you improve the cooperation between local, state, national, and international players? Because I know in Phoenix, some state government officials work directly with some national players or international players. And as they do that, there is probably from North Carolina, somebody is talking to an international player, and each one is competing against one another. That should not be the case. They should be working together. So that global governance, supply chain governance, is very critical. How do you improve the visibility and transparency in healthcare supply chains? If you ask me, that should be even priority number 1, because a lot of times we don't know in healthcare where goods are, when it's going to arrive, when would you predict a shortage, all those kind of things that are commonplace. So to you all in engineering and other places, please think of healthcare a place to use more AI tools in data analytics for prediction and coordination. So I can talk about that later if you want to. And last but not the least, remember that the fourth coordinate called the agility. How do you improve that agility in supply chains? Better coordinating the costs, repurposing where need be, and overall improve the supply chain practice that I talked about. So all those questions. So I'm going to stop here and let you mull over and ask me questions. And Srinivasan, you can tell me when it's time after that. So.
Yes, sir. Any questions from the audience? You can unmute yourself. You can ask the question directly. Ajit, you are on mute. Unmute yourself, please.
Hi, Dr. G. My name is Ajit.
Yeah,
I have a couple of questions, and it's
please.
pretty generic. But the first one is like, are we prepared for another pandemic? And I mean, I was going through your questions from the last slide, and I mean, you just explained the tools to leverage AI and everything. So there are lots of research left, if I'm not wrong. And my second question is, I've had several conversations with my seniors, and I was really interested in this healthcare supply chain systems. But some of my seniors were like, as an international immigrant, it's going to be very tough to get a job because healthcare is highly regulated and it comes under government. So, what is your opinion on that?
Okay, I'll take the easy one first, which is not an easy one either, which is, are we ready for another pandemic? Why do you want to wish another pandemic, Ajit? Come on, this one is enough. I think we'll be better prepared. Always, what risk teaches us, it's a kind of a stepping stone. So we will be better prepared, and I think we don't want to overdo things. We have to learn from this. I hope the globe comes together around United Nations healthcare to share some of the best practices that has worked. Because if you look at it, even from the COVID has two lessons taught us, right? One is how could we have controlled the spread? The second, right now we are going through what's the best way to vaccinate, which was also asked in the last question. So both have very interesting models across the globe. No two models are the same. I am based on what I know in this part of the world. And so you believe that we are all going to be presenting in international conferences and talking to international audiences to see how others have done it. If you look at it, people say South Korea was a classic example as to how they control the spread very effectively. Now, some things may work in some cultures, some might not work in other cultures. But that aside, at least if you have the transparency to the best practices, then that's a good step in the right direction for using it when a future pandemic or whatever the future risk that you want to look at healthcare, which is affected by shortages, not by the disease itself, but lack of resources to treating that particular disease. That was the sad thing. If we said there was not enough doctors or nurses, that's a different issue. You said you didn't have masks. That was sad. So I hope we learn from that, and I think there are things to do. Now, the second question, you are absolutely right about that, but here is how I have seen some of my students approach this. And you may want to think about this and see if your faculty or somebody has resources. One of the things healthcare is really interested is getting a digital footprint of flow through systems. Say, take an example of a cath lab. A cath lab is a place where people get angio done for them on their heart, or a little bit more detailed study of the heart. And it's an elective procedure, and so people are scheduled. And so whenever we know in a system, as an industrial engineers or management scientists or whoever it is, when systems are scheduled, there's always the efficiency versus effectiveness. What are the right things to do, which is your effectiveness? How do you do things right, which is your efficiency? So the trade-off between these two are always happening. And because healthcare is so regulated, they don't want to do the trial and error in the real world. So they want to take a digital footprint of this, which is your simulation model. I'm giving it a fancy name, and analyze it and provide a digital twin so that a manager or a healthcare supporter can look at it. I think that kind of an industry is growing more out of the analytics space. So it may not be directly touching a patient or working. So we are doing right now a project with Mayo. The only contact that we have, because I have international students working on that project when we have NDAs, is only an oncologist who talks to us. The rest of it is all information and data, which is given to us, and my students sit in labs and develop this, and now develop that as a skill set. So developing it as a skill set is critical. So just digitizing a flow in a healthcare system and understanding that, and it makes it even better if you can put a business perspective on it in addition to just the engineering perspective on it. What do I mean? Bring in the economics of doing that as opposed to the pure operational metrics that we normally use in a kind of an engineering setting. So I don't know whether I answered it thoroughly, but that's my experience has been.
Thank you so much.
Any last question? I think we have already exceeded time. One last question we can take, and then we will complete the session. Okay, if no one is going to ask, maybe I'll ask this last question and then we'll close the session. Sir, this question is primarily about, I don't know, how should I say, probably it is a political question, or is it something related with policies and regulations? Question is about the different countries have different policies in terms of healthcare. For instance, if I compare US versus India, we have so much of differences in terms of insurance policies, coverages, hospitals, the kind of medical expenses, and so on. So when we talk about global governance and global supply chain, make it into a one common platform and all, do you think it is practically possible?
No, to be honest with you, no. But that's where this has woken up all in different ways. So here's something, Srinivasan. India spends 1 to 2% of GDP on healthcare as a country.
Correct.
Not individually, you and me, or insurance based. US spends close to 15%. Outcomes might not be the same. So don't get me wrong. The people in India will live as long as the people in that. I'm not even going there. It is under these kind of a strained system, the need for a little bit more investment. So this budget in India, it moved the needle to about 3% for the first time. And the reason for that is vaccination. Not because anything structurally changed, but vaccination needed money. So it changed. So it's good. Hopefully they stick on to those 3% even after this, which then opens up the discussion on structural changes. Okay, so that and from the US perspective, we have to learn the opposite. How do I do this more efficiently? For example, GE used to do what's called as a reverse innovation. They would take kind of a ultrasound machine, which used to be humongous here, take it to Indian villages where you have to have it very portable and small. So they left the Indian engineers design and test one. And when it became so effective, they started re-importing it here and using it in various places. So that kind of a reverse engineering is important for even a developed nation to learn, to adopt those kind of best practices. So what cannot stop Srinivasan, irrespective of whether it's a developed, whatever economy, is understanding supply chain and its best practices. And we are doing it right now. So we at ASU have a USAID grant. USAID is the United Nations International Aid Development. So they have given us a grant to work with Africa and Ghana. So we have a straight tie-up with a university in Ghana that we meet almost weekly, and addressing healthcare and agricultural supply chains through these relationships to strengthen their capacity. So our best practices has to be adapted. It cannot be taken and used as is. And we are also learning a lot from them as we are doing this. So that, when we can happen at one-on-one, should happen more globally. And this is a good driver for this. COVID has become an excellent driver for it. So.
Thank you so much. I think we have already run out of time. Thanks once again, Dr. G. Your presentation, especially on the practical implications, what is on the ground, and what supply demand factors, including the economic aspects, really opens eyes for us. I mean, we always tend to see more math models and simulation, but this is really a fantastic presentation because it is talking directly what is there on the ground, how we need to prepare ourselves. So on behalf of Informs NCSC chapter, we once again thank you. So I hope we will have one good occasion coming in the future, and then we will invite and have a better presentation in terms of other topics in healthcare supply chain. Thanks a lot.
Thank you, Srinivasan, and good luck to each and everyone who has been on the call. Best wishes. Stay safe.
Thanks a lot. Thanks a lot. Bye-bye. Thanks, participants.
Thanks.